very pleased to be here today to be talking about screening for early disease detection and the fact that it's not as simple as it seems. Just recently, in May of 2012, the U.S. Preventive Services Task Force final report said that most men of any age should not routinely get PSA, prostate-specific antigen screening, for early detection of prostate cancer. And they made that decision based on a review of 30 studies and said, does not save lives, leads to unnecessary anxiety, surgery, and complications from treatment of slow-growing cancers that never would have become life-threatening. And they concluded that the life-saving benefit was at best very small and offset by overdiagnosis and overtreatment of non-lethal cancers. Well, you can imagine that that got a lot of reaction. People said that it was sparking controversy. Men were left to wonder as the PSA test was disputed. And the confusing thing about it was that it would seem that PSA screening for prostate cancer should be just so straightforward. It's a simple blood test. It has the right mechanism of measuring protein in blood that's produced by the prostate tissue. It's widely accepted and used, routinely given to over 75% of men in the United States over the age of 50. It is the most common way, PSA testing, the most common way that the diagnosis of prostate cancer is in fact triggered. And it picks up prostate cancer long before the symptoms, significantly increasing the number of prostate cancers diagnosed at very early stages. So you would think that treating prostate cancer earlier would lead to better prognosis. But does it? And can it be harmful? Are there risks associated with it? Well, PSA testing for prostate cancer really reflects and illustrates the conundrum of screening, that there are conflicting emotions regarding screening for early disease detection, whether it be from the public side, the clinician side, the insurer side. On the positive side, screening intuitively holds such promise. How could early detection not be beneficial? How could we not offer and want to receive screening tests? But on the negative side, the population data are not clear that screening itself has actually worked. For some cancers, yes, it has led to an increase in diagnosis, but it hasn't always led to a decrease in mortality. And there have been some cancers, like stomach and cervical cancer, where the mortality has decreased, but there's absolutely no way that could have been done due to screening, because there is no screen for stomach cancer, and the decline of cervical cancer happened before the screen was introduced. Why is the effect of screening so difficult to evaluate? To understand that, we have to go back and understand the first principles of screening. Screening for early disease detection is the application of a simple test to asymptomatic persons in order to classify them as likely or unlikely to have a disease. Screening that we're talking about now is not screening for the safety of others. This is screening where you have a personal benefit on your own prognosis. And the key words in that definition that we need to remember is that screening is searching for early asymptomatic disease. Once the disease has symptoms, you are out of the screening phase into a diagnosis due to clinical symptoms. The assumption underneath screening and the real purpose for doing screening is that early detection asymptomatically will lead to a more favorable prognosis. In other words, that treatment given before symptoms develop will be more beneficial than waiting till evidence of the disease comes forward. Also remember that screening is not a diagnostic test, that screening classifies the person as likely or unlikely to have a certain disease. Then you apply the diagnostic test. For screening to be successful, we need three things. We need a suitable disease, we need a suitable test, and we need a suitable screening program. Well, what are appropriate diseases for screening? First, they're diseases with serious outcomes. Either in actuality, like cancer, cardiovascular disease, a serious disease, or a disease that is perceived to be serious by the community. An appropriate disease for screening also requires that treatment given before symptoms develop is more beneficial than treatment that's given after symptoms develop in terms of morbidity and mortality. So if a disease treated asymptomatically will be just as highly fatal or just as highly curable if you waited for symptoms to develop, then that disease would not be a good candidate for screening. It is a good candidate if it makes a difference if you treat it before symptoms develop. The other thing that's required for an appropriate disease for screening is that the prevalence of the detectable preclinical phase is high in the screened population. The period of time where the disease is asymptomatic, it's preclinical, and we have a screening test that is able to detect it or pick it up. Now, we'll talk about what that means in just one second, but a point I do want to make is you do not need all three of these to be an appropriate disease for screening. For example, screening newborns for phenylketonuria doesn't have all three of the conditions. It is not a common outcome, this inborn error of metabolism. But on the other hand, it has such serious consequences that can be avoided if the dietary modifications begin at birth, that it is considered to be something that we routinely screen for, even though few babies will actually have it. So let's go back for a second and understand that detectable preclinical disease phase. If we think about the natural history of the disease, at some point there is a biological onset of the disease. Then at some point the disease may be detectable by screen. But we don't have screening all the time, so we probably won't pick it up at the time it becomes detectable. But at some point a screen will be done. So that's the next cutoff. And then at some point, if we waited and didn't do a screen, the disease would be diagnosed by symptoms. And then sometime after that, the person would die. The detectable preclinical phase is the preclinical phase prior to diagnosis, which is detectable where the disease is detectable by screen. So it is the period of time bracketed between when it is detectable by screen, that's when it begins, to when it ends, when it is diagnosed by symptoms. That is the detectable preclinical phase. So for screening to be successful, we also need a suitable test. And an appropriate screening test is one that is simple, it's inexpensive, it's easy to administer, and it's acceptable to a large number of potential screenees, because this is going to be given to a very wide number of people. We also need the test, though, to be valid, and a valid test does what the test is supposed to do. If you have the disease, the test should screen positive, and that means it's going to have high sensitivity. If you don't have the disease, then you want the screening test to test negative. You have high specificity of the disease. So the test should do what it's supposed to do. If the person has the disease, the test should screen positive. If they don't, the test should screen negative. And we can do that by actually calculating sensitivity and specificity. So the screening test, we can set up a 2x2 table where the result of the screening test is on one axis, and the gold standard, whether the person actually has the disease or not, as evidenced by the diagnostic test, will be on the other axis. So A will be the true positives. The person screens positive on the test, the screening test, and in fact does have the disease. B are false positives. They tested positive on the screening test, but after the diagnostic test was done, they in fact were not found to have the disease. C is false negatives. The person tested negative on the screening test, but in fact did have the disease and the screening test missed it. And D, false negatives. They tested negative on the screening test, and in fact they did not have the disease. The sensitivity will be the probability that the person tests positive on the screening test, given that they actually do have the disease. The specificity is the probability the person tests negative on the screening test, given that in fact they do not have the disease. So the sensitivity will be A over A plus C. Out of all of those who have a diagnostic test that's positive, they really do have the disease, A plus C, 8 of them tested positive on the screening test, sensitivity. And on the specificity, out of all of those who do not have the disease, B plus D, the probability or the proportion of those who tested negative on the screening test, D divided by B plus D, the specificity. So in fact, if we use data, and we use the data from the Health Insurance Plan of New York, where the screening test was mammography plus a physical exam, and the outcome was breast cancer diagnosed through a biopsy. Well, in this study, there were 64,810 women who participated in the study. Of those, 1,115 tested positive on the mammography. It was mammography plus physical exam, we'll call it mammography. And the other 63,695 women tested negative on the mammography. All the women who tested positive on the mammography went and had a breast biopsy. So 1,115 women went on to have a breast biopsy. Of those biopsies, 132 women actually have breast cancer after the biopsy. And the remaining women, 983, had a biopsy, but they were cancer-free. Now, of the 63,695 women who tested negative on the mammogram, 45 women were diagnosed with breast cancer by symptoms, by clinical symptoms, within the next 1-year period of time. What we know about mammography is that it should advance the diagnosis of breast cancer by about a year. So those 45 women were actually missed by the mammogram. They should have been able to be picked up. Now, that's a very conservative statement because there's no question that some of those women really did not have the disease when the mammogram was done. They just have a rapid, very aggressive disease. It was not there to be picked up at the mammogram, but it became not only able to be picked up by a screen, but it was picked up by symptoms within a 1-year period of time. But conservatively, we're going to say the mammogram missed them. And the other 63,650 women had a negative mammogram and had no clinical evidence of breast cancer within the next 1-year period of time. So they are considered true negatives. The sensitivity of the mammogram is the probability that the woman tested positive given that she had breast cancer. So that's 132 out of 177 or 75%. And the specificity is the probability that she tested negative given that she did not have breast cancer, 63,650 over 64,633 or 98.5%. And what this means is that screening was very good at identifying women who did not have cancer, specificity, 98.5%, but missed 25% of women who did have cancer. So the sensitivity was only 75%. Well, can we do anything about sensitivity and specificity? Can we modify them in some way? Well, it turns out that it's going to be dependent on the criterion of positivity. As we all know, some test results are going to be clearly negative, some test results are going to be clearly positive, and there's going to be a gray zone in between, where at some point we are going to put down a line and say everything below this is going to be negative and everything above this cutoff is going to be positive. And that is a criterion of positivity, the test value at which the screening test outcome is considered to be positive. Well, by modifying the criterion of positivity, we can actually influence both the sensitivity and specificity of the screening test. So let's say that we are interested in screening for blood pressure, and 140 over 90 is going to be the level that we really are going to want to detect when we talk about hypertension. Well, let's say we lower our criterion of positivity. Let's say we're going to screen and pick up anybody whose blood pressure is 132 over 80, much lower than actually the value that we're looking for. By lowering that criterion of positivity, we are going to have a very sensitive test. We are going to pick up absolutely everybody who has hypertension. But there are going to be a lot of people we pick up by our screen who don't end up being hypertensive by our examination. So we are going to have a very much lower specificity because there will be many people who are positive on our screen but don't end up being diagnosed with hypertension. If, on the other hand, we increase our criterion of positivity, let's say we go to 160 over 105, we are going to lower our sensitivity. We are going to miss some hypertensive cases. But we are not going to send anybody through a diagnosis of hypertension without reason. All of those that we send through are actually going to be hypertensive. So our sensitivity will have been lowered, but our specificity will have been increased. So that you can see that the sensitivity and the specificity are characteristics of the screening test, but they can be modified and traded off against each other. We have to weigh the cost of a false positive, the cost of saying that someone might be hypertensive, and sending them to their healthcare provider to go through a diagnostic test to figure out if they truly are hypertensive or not, unnecessarily. Against the cost of false negatives, reassuring someone that they do not have, in fact, breast cancer because their mammogram was normal, or they do not have hypertension because their screen for hypertension was normal, and lulling them into a false sense of security based on our screening test, when in fact we're wrong, and when in fact they actually do have the disease. So we said we needed a suitable disease, we said we needed a suitable test, and now we need a suitable screening program. And the evaluation of a screening program is going to have two components to it. It's going to have the component of feasibility. Can we actually do the screening program? And effectiveness. Let's say we can do the screening program. Does it matter if we do it? Does it make a difference to prognosis if we do this screening program? So the first thing we want to look at in our evaluation of a screening program is feasibility. And feasibility has a number of components to it. First is simply acceptability. Are we delivering the screening program to the people that we want to deliver it to? So the acceptability of the screening test to our potential screenees. And we usually measure that by the proportion of the target population who are screened. So of those that we wanted to reach with our screening program, what is the proportion of that population that was actually screened? But it actually is going to turn out we have to do one more thing beyond that. We simply cannot just screen them and leave them then with no ability to figure out whether they actually do have the disease or not. They actually need to go in and be diagnosed based on what their response was to our screening program. So the second thing we want to look at is the success of follow-up, the proportion of those who test positive who actually receive the diagnostic test and the treatment as indicated. And there are two different things. One of them is to make sure that we have set up an ability in our community for them to go somewhere and actually get a diagnostic test, and then put them in a position where, if treatment is necessary and they want that treatment, that they can receive it. So the success of follow-up. We also want to understand our costs and the cost effectiveness of the screening program. The cost is very simple. We can just look at the total cost of the screening program. But many would argue it makes a difference whether then you detect one case for that cost or you detect thousands of cases for that cost. So you can actually do a cost per case detected, which gives you a little bit more of the cost effectiveness measure. Related to that then is to understand our yield of the screening program, meaning how many who tested positive on the screen actually do have the disease after the diagnostic test has been done. So it's called a predictive value of a positive test. And we can actually do a predictive value of a negative test also, but primarily people will look at the predictive value of a positive test. The predictive value of a screening test is calculated in the following way. The predictive value positive is calculated by basically looking at the screening program the opposite way from the sensitivity and the specificity. Sensitivity and specificity were related to the test. So we wanted to know how well the test did. So we looked at among all those who have the disease, what proportion test positive, and specificity among all those who do not have the disease, how many test negative. But in a predictive value, we want to invert that and say, if I test positive, if a patient tests positive, what is the probability that they will actually be diagnosed with the disease once the diagnostic test is done? So predictive value positive is the probability that the person has the disease given that they test positive. And the predictive value negative would be the probability that the person does not have the disease given that they test negative. So predictive value positive and predictive value negative, of course, will depend on the sensitivity and the specificity of the screening test. You need to have a good test for you to be able to predict whether you have the disease or not. But more importantly, they are going to depend on the prevalence of the detectable preclinical disease in the screen population. How common is the disease that you are screening for among the detectable preclinical phase of the disease in your population? So if we go back to our mammography and our breast cancer example, the predictive value positive will be, of all of those who tested positive, 1,115, what proportion of those actually had the disease after the biopsy was done? So 132 out of 1,115, or 12%. So that means that a woman who has a positive mammogram has a 12% probability of going on to be diagnosed with breast cancer after her biopsy. And the predictive value of the negative test means of all of those who tested negative on their screen, what probability have the disease negative? When they're finished with the biopsy, they will be told they did not have breast cancer. So that's 63,650 out of 63,695, or 99.9%. Well, how can we change that predictive value positive? I mean, basically what we're saying here is in this particular screen, only 12% of the women who were indicated to test positive on their screen actually do have breast cancer. Is there anything we can do about that? Well, we cannot do much to change sensitivity and specificity of the test. We talked about that previously, and it really is a characteristic of the test that we have available. But we can change the prevalence of the detectable preclinical phase. What does that mean? It means that we can target our screening test to a population that has more people in the population who are likely to have the outcome or the disease, so that we can basically screen a higher risk group. So rather than screening for breast cancer among teenage girls who are unlikely to have breast cancer to a great degree, we can target our screening program to women over the age of 50 who have a family history of breast cancer, a personal history of benign breast disease, maybe have a late age at first birth. By doing a higher risk group, we will have more women in the detectable preclinical phase. That will increase the prevalence in that phase, and it will increase the predictive value positive of our screening test. And the other way to do it is to do one screening test that is not that predictive. But then for those that tested positive, go ahead and simply give them a second screening test, so that basically we're building a second test on top of a first test. So we now talked about how to look at the feasibility of a screening program. Now we need to look at the effectiveness of a screening program. And there's two ways that we can do that. We can look at early outcome measures, And then we can look at a more definitive measure, which is going to be mortality. So the early outcome measures mean that we're picking up early disease. We just confirm that we are picking up early disease. If it's cancer, for example, we want to demonstrate that we shifted the stage distribution of the disease to the left, which means we picked up more early stages of that cancer, which we would think would be less severe disease. Well, that in itself is excellent to show that we are picking up early disease. It's almost necessary to show that. But what is the relationship with prognosis? We all know that even early stages of the disease can sometimes have a bad prognosis, and sometimes late stages of the disease end up having a good prognosis. So we don't know it is not clear that having early stages of the disease picked up means that we are necessarily going to have a better prognosis and necessarily going to save lives. There's not a one-to-one correlation there with that. So what would be better for us to look at? Well, the very best thing and most definitive thing we could look at is to look at cause-specific mortality rates and look at these cause-specific mortality rates and compare them for both the screened and the unscreened individuals. But when we do that, though, there are going to be some special issues that we're going to need to look at. We can go ahead and actually look at the effectiveness through any epidemiologic design strategy, through a randomized clinical trial, through an observation study. But there will be special issues in the evaluation of a screening program that we will need to take into account that just aren't relevant to other kinds of evaluations that we might be doing. We're going to need to look at volunteer bias if we're doing an observational study, and we're going to need to look at lead time bias and length bias even if we're doing a randomized trial. Volunteer bias just says that if you're doing an observational study and you're going to go ahead and look for people who volunteered to screen versus people who did not volunteer to go through a screening program, basically, we're going to be comparing those who self-select to be screened versus those who self-select to not go through a screening program. And it's going to turn out that those who volunteer for screening are going to be systematically different than non-volunteers. And they're going to be different in ways that are related to the outcome under study. In other words, there's going to be confounding simply because you volunteered to be in a screening program. You're going to be different than those who do not. They could be healthier people. They could be people at higher risk of developing the outcome under study, so they're more scared people. And so whether it goes one way or the other, they have less risk factors or they have more risk factors. The fact is those who volunteered for screening are going to be different from those who do not. And we're going to need to take those variables into account when we look at their risk of developing the outcome under study, like the development of the disease, or more importantly, the survival of the disease. So development of the disease, morbidity, mortality from the disease. The other two are really unique to screening. And the first is lead time bias. Lead time says that in every screening program, you actually have advanced the diagnosis just because you did a screening test. In other words, these people are asymptomatic. On that day, they had absolutely no symptoms of this disease. On that day, they would have not come into their healthcare provider and said, I have a symptom, I need you to look at it, and then they diagnosed the disease because there were no symptoms. So by picking up the disease by screening while the person is asymptomatic, you are advancing the diagnosis of the disease. So lead time represents the time between when the disease was diagnosed because of the screening test and when the diagnosis would have occurred by clinical symptoms. And with lead time bias, because by definition the diagnosis is always advanced by the screening program, cases that are detected by the screening may actually incorrectly appear to survive longer only because of their earlier diagnosis. In other words, they don't live any longer, but it looks like there's a longer time from diagnosis to death, which could be misinterpreted as having a longer survival. So again, let's do a picture and then do an example. We had talked about the biological onset of the disease, then the time when the disease could be detectable by screen, the time when you actually did screen for the disease, and then the time when the diagnosis was made by symptoms, and finally the time when the patient died. We talked about the detectable preclinical phase, when the disease could have been detectable by screen, and then when it was no longer able to be detectable by screen because it was being diagnosed by symptoms. But there's now one more time, which is the time between when the screen was done and when the diagnosis was made by symptoms. And this is the lead time. This is the time by which the diagnosis is pulled forward from when it would have occurred by symptoms because you actually did a screening test. So let me give you an example of how we could be misled if we don't take that into account, that lead time. Let's say a randomized trial was conducted to evaluate the effectiveness of a new screening program for colon cancer. Among those whose cancers were detected by the screening program, their average age of diagnosis was 54 years, and their average age of death was 60 years. So the average survival from diagnosis to death was 6 years. For those who were detected by clinical symptoms, their average age of diagnosis was 56 years. Their average age of death was 60 years. Thus, their average survival from diagnosis to death was 4 years. The investigator reported in the article that there was a statistically significant 2-year increase in survival from colon cancer associated with screening. As the question goes, what is wrong with this picture? Well, what's wrong with this picture is that both groups, the screening group and the symptoms group, both died at age 60. So there was no increase in survival. What there was an increase in the time that the person knew that they had the cancer. So those who were picked up by screen, as you can see on the diagram, were picked up at age 54. Those who were picked up by symptoms were picked up at age 56. That 2-year period is the lead time by which the diagnosis by symptoms was advanced because it was picked up by the screen. That needs to be taken into account in some way. It isn't that they lived longer, but they were aware of their diagnosis. They lived with the disease knowledge 2 years more than those with symptoms. Now, many could argue that that's useful. The person has more time to make plans, to sort of adjust to the disease. Maybe the treatment, if it's early stage, is not quite as debilitating as those when symptoms are developed. So all of those are good things, but it doesn't change the fact that the person lived no longer. And that's something that people need to understand if that is true. So the problem was that lead time bias was not taken into account. We should never use duration, average survival, from screen to death and from symptoms to death without taking lead time into account. And the easiest way to do that is simply compare the age-specific mortality rate. Just see the death rates from colon cancer at age 60 from those who are diagnosed by screen versus those who are diagnosed by symptoms. Now, the last type of bias that we need to always think about is length bias. And length bias is a little hard to understand, but let me try to explain it intuitively before the definition. When we go out the very first time and we do a screening program, I very much think about it as putting a net in the water and just scooping up everybody who is existing with the disease out in our population at that point in time. There are going to be prevalent cases, people who may have had the disease for years or decades, or those who have just developed the disease. But it is going to be very much a mixture of those who have very advanced disease because they've had it for a very short period of time, it's very aggressive, and those who have had the disease for decades and might therefore be thought to have a very, quote, benign form of the disease, not as aggressive, which would have done just fine anyhow, even if you had never picked them up by the screening program. So length bias says that the initial screen will be overrepresented by disease that has a longer duration in the detectable preclinical phase, prevalent cases, which are usually less aggressive and have a better prognosis compared to incident cases, where incident cases are the ones that have made the change over to symptoms, to being picked up clinically. Now, we have to in some way take that into account. That's very hard to do. The way that people try to do it is by looking at subsequent screening tests. So it's going to be the very worst at the very first screening test. After that, you are just taking people who screened negative on the screen and repeating the screen, maybe 1 year later, 2 years later, or 5 years later. So they don't have as long a time to be sitting out there without clinical symptoms. So it reduces the overrepresentation of people with long duration. And that is why you will often see people citing length bias, but saying, but on subsequent screens, we still saw a benefit in survival among those whose disease was picked up by the screening program. So in summary, what we have tried to do is basically just raise our awareness that the appropriateness of screening for disease control is just not always clear. We need an appropriate disease. We need an appropriate screening test, one that's valid, that has adequate, appropriate sensitivity and specificity. We need to evaluate the screening program, both with respect to its feasibility, looking at predictive value, and its effectiveness after we control for special types of confounding and bias. And we will find that some diseases are considered to be good and some are considered to be not good candidates for screening. That a breast cancer, colon cancer, hypertension, glaucoma, diseases like that are considered to be excellent candidates for screening programs. A serious disease where a valid screening test exists and early treatment has been shown to make a difference. But then we will hear people say that ovarian cancer or pancreatic cancers are not good candidates for screening. And what is usually meant by that is that we, in 2013, just do not have an adequate screening test currently available that will advance the treatment far enough to make a difference in prognosis if the disease, these cancers, are picked up asymptomatically. This is really a flaw of our abilities to have a good screening test, that it can advance the pickup of the disease enough to make a difference in terms of prognosis if you started treatment asymptomatically rather than symptomatically. And now we come back and close with prostate. Where is prostate in all this? A good disease or not a good disease? And why was that decision made? Remember we said that PSA, prostate-specific antigen, seems so attractive, that it would seem straightforward. It's a major cancer in men, so check off that it's a serious disease. It's a simple blood test that it's widely accepted in use, and it picks up prostate cancer long before the symptoms. So it seems like we have an acceptable test and we have a screening test that's valid. There are a significantly increased number of cancers that are diagnosed at the very early stages. So we sort of have that first part of effectiveness where we have sort of shifted the stage curve to the left. But how about the second part? Is there a better prognosis if we treat in the asymptomatic stage? Does this translate into a reduction in death rates, and are there risks of the screening? And this is the part that we just didn't really at first think was going to be an issue, but it turns out to be for the following reasons. The bottom line is that many randomized clinical trials have been done, but they have not found the life-saving benefit of PSA screening 10 years after the diagnosis of prostate cancer. And the postulated reason is that many prostate cancers that are detected by PSA screening are very slow growing, and in fact might never have caused problems if they had not been diagnosed because of the screening. This is the length bias. than that. Many patients have said that the diagnostic biopsy plus the treatment, surgery or radiation, is actually worse than the disease itself. And what the real problem from our standpoint is we're not sure what PSA level actually signals cancer. So there are going to be many false alarms. And in fact, 13% of men who have regular PSA screening have at least one false PSA finding for every 4 screenings. And 6% of them will then have a biopsy for this false reading. So biopsies can be painful and can cause serious complications, infections, bleeding, urinary complications. But the real problem beyond that is if you do diagnose the prostate cancer, what do we do? What's sort of the commonly accepted standard of care at this point? Well, it turns out standard of care are 2 options. Option 1 is immediate surgery with radiation, perhaps, hormones. Option 2 is watchful waiting, active surveillance with periodic biopsies. Well, 20 to 30% of those with surgery and radiation have adverse effects, including urinary incontinence, erectile dysfunction, impotence, stroke, death, to go to the most extreme ones. And watchful waiting has a problem with a quality of life issue that many patients say, I can't deal with living with a cancer that is not removed. Just get it out. And unfortunately, we don't have a prostate screening test. PSA is not it. We do not have a prostate screening test that distinguishes a relatively harmless cancer that would continue on without developing into anything bad until the patient dies of something else like old age. We can't tell that one from a bad cancer that is going to become a rapidly growing, very aggressive, will in fact cause mortality. So the question that the group looked at when they made their recommendation is, how beneficial is it to treat prostate cancer early when the majority are not going to die of this disease and we can't predict who will die of the disease, and the diagnosis and treatment are going to cause morbidity in themselves? So you have very many emotional reactions from individuals, from clinicians, from insurers. From the individuals, when the recommendation came out that they did not recommend screening for all men, that they did not think it was a good risk-to-benefit ratio, there were emotional reactions from individuals in terms of our denying them a potentially life-saving test. Some clinicians will say, actually, I don't care whether this screening test saves lives or doesn't. It's irrelevant. It picks up early disease, and it brings people into the healthcare system routinely for exams. That in itself is going to help us save lives. But all agree that this is going to have implications for what Medicare and private insurers are going to pay for, that new federal healthcare law is going to base coverage requirements on these types of recommendations. What really is now the majority of clinicians are saying that none of these recommendations say that an individual can't have a screening test. For different men with different risk factors and different histories, we will make different decisions. But the important change is that we will inform men of the pros and the cons of the testing for their different risk factor profiles. So the message, I think, to us is just to raise our consciousness that there are a trade-off of benefits and risks of screening, that screening is complex, and that screening is intuitively attractive, but can really be a double-edged sword, and that we need to try to avoid our intuition and just conduct the necessary randomized trials for us to evaluate, that we need to look at the data when we're making a decision as to whether screening is a good thing or a not good thing for a condition or a disease that is of interest to us. Thank you very much.